And we are live. Good evening, YouTube. Good evening, Facebook. Welcome to tonight's session, which is entitled Are Statins Right for Me? Particularly in the context of those of you to whom we wrote with kidneys that aren't working quite as well as they might be. So there are two of us doing the talk tonight. My name is Vipin Bhardwaj. I'm a GP at Wokingham Medical Centre. I've been a GP there since 2005. I've been a GP since 1999. And I'm joined by my colleague.
And I'm Dr. Helen Rutherford, and I'm also a GP at Wokingham Medical Centre. I can beat Dr. Bhardwaj because I've been a GP since 1997, but I can't beat him in terms of being at Wokingham Medical Centre because I've only been there since 2016. But as you can see, both of us have an interest in what's called lifestyle medicine, and in particular in dealing with patients with diabetes and pre-diabetes.
And so this slide is there so that you've got an idea, a little bit more of an idea perhaps about us. There are a couple of bits that you can see relating to lifestyle medicine. I happen to be Modality's National Lifestyle Medicine Clinical Lead, and I'm also, as is Dr. Rutherford, a member of the British Society of Lifestyle Medicine. Now, what is that all about? Well, I'm going to explain a little bit in the next slide, but you can see the title of this says Introductions, which we've done, and Declarations of Interest. The Declaration of Interest is really that this is very much a methodology which is as old as the practice of medicine itself. Way before there were pills, people were helped by doing the basics. And what are the basics? Well, here you are. This is a screenshot from the website of the British Society of Lifestyle Medicine. And you can see various permutations and combinations of this on the internet. Some people have 4 pillars, some people have 5, some people have 7. Well, the British Society of Lifestyle Medicine, the BSLM, has settled on 6. And here they are. And they're what Dr. Rutherford and I call doing the basics, trying to eat in a sensible way, healthy nutrition, making sure that we can, where possible, as much as possible, get good quality sleep, trying to do some exercise, physical activity in some shape or form, ensuring our mental well-being, controlling stress, in other words, minimizing harmful substances. How long have we known that smoking is bad for us? Answer, since about the 1950s, and other things as well. And relationships, social connections, all these things are important, and we refer to this as doing the basics. And this is our sort of declaration of our bias. Where possible, Dr. Rutherford and I will always try and dig into those things when we're consulting with patients face to face, and try and help patients in that regard. So this is what we're going to cover tonight. Please, as you go along, feel free to put questions into the chat. Dr. Rutherford and I split the session into 2. I'll do the first bit, and Dr. Rutherford will be monitoring the chat for questions, and then we'll switch over halfway. So we'll actually start with some questions, which will hopefully help define exactly what the sort of the problem that we're trying to tackle tonight is. There's a term here that some of you will be familiar with, some will not. We've written to you with the invite for tonight's sessions, particularly about the government guidance, the NHS guidance on the use of statins for people with kidneys that aren't working so well. The medical term for kidneys not working so well is on this slide, chronic kidney disease. And we'll just dig into that a little bit, explain why it's important. Dr. Rutherford will go on and talk about statins, the pros and cons, to help you decide, as per the title of tonight's session, are statins right for you? And then we'll finish off with the obligatory and finally slide. Excuse me. Now, Dr. Rutherford and I have been doing sessions like this, both remotely like this, but more often face-to-face in practice since 2016. And every single presentation we've ever done has this slide in it. This, to some extent, is a reminder to all of us in the medical profession, but to some extent those who are our patients, of the limits of medical evidence, medical wisdom, medical techniques, medical research, etc. And this was put as beautifully as I think I've ever seen it put by the former dean of Harvard Medical School. Harvard Medical School, most of you will have heard of, not exactly a third-rate outfit. And so Dr. Burwell was credited with telling every single new intake of medical students in the time that he was the dean. He would tell every single new medical student that half of what Harvard was going to teach them was going to be wrong. The problem, of course, was nobody knew at that stage which half was going to be wrong. This was not being done deliberately. This was just a demonstration of the fact that at any one time, we may think we have certainty about our knowledge, but actually half of that is probably incorrect. And that, I think, is important for us as the clinicians to understand, and hopefully you'll see some of that during the course of tonight. So we'll start with some questions, and you are very welcome. In fact, you're encouraged to try and answer these. I'll perhaps give a few seconds. If there aren't any answers, then I'll just move on. So the first thing is this term that I've just sort of thrown at you, as it were, chronic kidney disease. What exactly is that? So I'll pause maybe for a few seconds in case anybody wants to put something into the chat. Helen, if there's nothing for a few seconds, just let me know and I'll move on.
It looks like everyone is pretty shy tonight. So okay. I think I'd move on if I were you.
Okay. So in order to try and answer that question, it's probably a good starting point to actually think about, what do kidneys do? What's their job? And I usually come up with a slightly sort of cooking analogy. So for those of you who are chefs, maybe some of you have tried to make a bit of stock, vegetable stock, chicken stock, whatever it might be. And so you've got the sort of the veg bits, and you've got the water, which has got flavored, and then you try and filter it through a sieve. And you're pouring the whole mixture through the sieve, and then the bits, the veg bits or the chicken bone bits, they're kept in the sieve, and the water goes through into the pot. Now, the rate at which you sieve the stock is dependent entirely upon you. You can put it very, very slowly, or you can speed it up and really sort of chuck it through the sieve. Well, the kidneys are effectively our body's sieves. So our blood is, I'm putting this quite simplistically, but it's a good way to think about it. Our blood is being passed through the kidneys and filtered. And the filter keeps the things that need to be kept inside the body. Cells, protein particularly. And the waste material is basically got rid of through our urine. So we pee it out. Now, this thing that is mentioned in this slide, the way that we define chronic kidney disease is with reference to the rate at which the blood is filtered through the kidneys. And that's called the glomerular filtration rate. That is basically the same as the way that those of us that make stock pass the stock liquid through the sieve. So the rate at which the blood is filtered through the kidneys is the glomerular filtration rate. And if that rate goes down, as it does with age and with other conditions, that gives rise to this term chronic kidney disease. Now, many of us in the medical profession really are pretty unhappy with that title because it sounds bad, doesn't it? Chronic kidney disease. And it can be bad, but it's very, 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 very rarely bad. More often than not, it's a reflection of simply getting a little older. The rate at which the blood flow passes through the kidneys reduces. But it's not just as a result of getting older. It can be as a result of other things, and it can have implications. More of that a little bit. So this slide, to some extent, sort of summarizes what kidneys do. And then we come to an important thing to reflect on, and really a point of reassurance for most people. Many folks get worried when they see, for instance, in their record that it says chronic kidney disease. Very, 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 very few patients with chronic kidney disease go on to have anything like dialysis. It's not really one of the common consequences of chronic kidney disease. The importance of chronic kidney disease actually relates to something completely different, and we're going to come on to that in a couple of slides' time. So this slide, which is taken from Kidney Care UK's website, says that the term chronic, which some people think means really bad, actually doesn't mean really bad. It just means it's gone on for a long time. That's compared to acute, which means a short time. And it does not usually mean that anything bad is going to happen to the kidneys. What we typically do with somebody who is diagnosed with chronic kidney disease is that we will monitor over a period of time. So every year there'll be blood tests, at least one, sometimes more, depending on other medications. Usually there'll be a urine test as well to see whether that sieving function of the kidneys is still working as well, or is the sieve no longer working so well that things are actually starting to come through the sieve, such as cells and protein. There are a couple of important factors that have to be taken into account when it comes to chronic kidney disease. People with chronic kidney disease are sometimes put on other medications for other conditions, diabetes, high blood pressure, etc. And those medications should be continued unless a healthcare professional advises you to stop. Now, there are certain conditions which can affect the kidneys badly, particularly over the sort of the winter time. And those conditions can be made worse by taking certain medications. And so the NHS a few years ago produced what are called sick day rules cards. And we, Dr. Rutherford and I, have left a supply of those at reception so that you can go and collect them at some point. There's no urgency to this, but you can go along to reception at Woking Medical Centre and collect one. And what the sick day rules cards give you guidance on is to tell you that if you are on certain medications, certain types of medications only, and you become sick, hence the term sick day rules, then you must stop taking those medications until you get better. So a typical example might be over the course of the winter, you might have, let's say, the winter vomiting bug. You're not taking much in the way of food or drink, and therefore certain medications can become almost more powerful as a result of not eating perfectly, not drinking perfectly. And what can happen is that the kidneys become slightly, and it's temporarily, they become slightly temporarily damaged. They don't work so well. People sometimes end up in hospital. So the sick day rules guidance says that if you get one of those conditions, winter vomiting bug, flu-like illness, those sorts of things, you must stop those certain medications until such time as you feel better. This is all written on the card. It's important to avoid certain types of pain-killing medication altogether. And those are sort of listed on here. Things like over-the-counter ibuprofen, medication which you might not actually give a second thought to. You get a bit of maybe a back sprain from having done some gardening. You might think, oh, I'll just take some ibuprofen. But remember, you've got this CKD, chronic kidney disease. And if somebody like me as a clinician has a little moment of forgetfulness and attempts to prescribe it, just remind the clinician, no, I shouldn't be taking that. I've got CKD. Now, there may be times when there's no other option, and then we will prescribe it with a degree of care, and we'll go for the shortest possible duration of treatment. This may seem a little niche, this sort of reference to herbal remedies, but people do go off and get quote unquote herbal remedies. It's important to bear in mind that the herbal remedy / sort of natural remedy industry is very, very unregulated. They're not regarded as drugs for sort of legal purposes. They're actually regarded as food additives, and they're not tested in anywhere near the same way. And therefore, because they're not tested, we have simply no understanding of what the ingredients are and how they actually affect the kidneys. If your kidneys are perfectly fine, then it's less important. But if the kidneys are already not working so well, then this becomes potentially more important. So one to bear in mind. Now, I'm going to anticipate that the answer to this is hardly anybody knows their EGFR. So that's the thing I've just mentioned. That's what's called the glomerular filtration rate. Remember my sort of visual analogy of a sort of a pot of stock being poured through the sieve. You can put it through slowly or you can put it fast. That's the number that we get. And here you can see it listed. And actually, the only bit that we're really interested in as doctors is the categories that you see highlighted in red: stages 3, 4, and 5. CKD stage 3 is the overwhelmingly most common one for those who have it. Actually, most people don't have any CKD at all, but those who do, it tends to be CKD stage 3. And you can see from a numbers perspective, that's between 30 and 59. And I suspect almost all of you who are joining tonight are in that category, and almost none of you are in the sort of stage 4 and 5. That is, as you can see, very, very severely reduced kidney function. And by the time you're into sort of stage 5, most people are having dialysis or waiting for a transplant. And as I've already said, that's incredibly unlikely to happen. So this hopefully gives you a feel for how we categorize the severity of CKD. So this is the big bit. Why is CKD, why is chronic kidney disease important? Because I've already said, actually, it's not that important from the perspective of people ending up with damaged kidneys, dialysis, transplants, etc. What it actually is one of the risk factors for this thing called cardiovascular disease. What is cardiovascular disease? Cardiovascular disease, or CVD, to which it's usually abbreviated to, encompasses conditions such as heart disease, strokes, and mini strokes. When I'm explaining this to patients, I sometimes refer to this as the body's plumbing. So it's the pipe work within the body that takes blood from the heart to where it's needed. And where it's needed is actually everywhere, but the heart itself needs blood. It needs blood very, very early in the sort of the anatomy of the supply, obviously the brain. So these are important areas, and if the blood flow to the heart itself and to the brain is reduced for any reason, that can cause problems. And for many years, cardiovascular disease has been the most common cause of death in the UK. And as you can see, the numbers are reasonably significant. Now, we're interested in trying to prevent some of these deaths, as many as possible. And so we might ask ourselves, well, what are the underlying causes? What are the underlying risk factors? There tend to be risk factors. And as you can see from this slide, some of them are things that we can't actually necessarily do that much about. If we have a very strong family history, a genetic predisposition, as they say, you can choose your friends, but you can't choose your family. We can't do that much about it. And it comes as quite a surprise to a lot of people that environmental factors, one of them as basic as being relatively poor, increases the risk. That's often summed up as the term health inequality. We can't do that much about that, but what we can do something about is what we sometimes refer to as the modifiable risk factors. So the things that we can actually change. And you can see that highlighted at the bottom here in red. So a poor diet, for instance, and just generally poor lifestyle, again, reflecting back to the 6 pillars of the BSLM: diet, exercise, sleep, stress management, noxious substances, and social relationships. Those are some of the pillars that we can do things about. And as you can see from this side, it is actually thought that roughly a third of all CVD deaths are related to lifestyle factors. So one of the things that is perhaps worth putting into context is how important a risk factor is CKD. The next slide, I'm going to just go through some of the principal risk factors. How important is CKD in the overall risk? And this is a graph from the very reputable Lancet magazine. And what it shows is how the risk of cardiovascular mortality. What does cardiovascular mortality mean? It means dying of CVD. CVD, remember, encompasses heart disease, strokes, and mini strokes. So the risk of dying of that, and that is compared to what the eGFR is. So remember, stage 3, CKD stage 3 is anything under about 60. And so you can see here how the lines are pretty flat. The numbers don't necessarily mean a huge amount. They obviously do, but for the purposes of tonight's sessions, it's more the pattern and the direction of travel that is most important. So as I said, most of you will be in the range. In reality, most people on this session tonight will be somewhere around 50 to 60, the vast majority. So what you can see here is that the risk, and the reason that there are different colored graphs is a reflection on how much protein is being lost through the urine. If you remember back to the sieve, if the holes in the sieve are really wide, then lots of sort of veg and chicken bones get through. In the body's case, if the filtration isn't working that well, then things like protein and cells can get through. And so if somebody has more leaky kidneys, there'll be more protein getting through. The implications of that are worse. But what you can see, in a sense, whatever the difference between these lines, what you can see is that this rise in risk of heart disease and strokes occurs with a very low eGFR. So you really have to get down well below 40, more like 30, for the graph to start to rise, indicating that you really have to get down. If I just back up a little bit, just temporarily, just to remind us what the numbers are. CKD stage 3, 30 to 59, and then stage 4 is 15 to 29, and then stage 5 is less than 15. So as I said, the overwhelming majority of people on this call will really be between sort of 50 and 59, but it's really once we get down to the 30s, mid 30s, that the rate starts to rise. What is that telling us? That's telling us that as a risk factor, yes, it's a known risk factor, but the level of kidney deterioration, the level of kidney damage, if we want to use that word, has to be quite significant. So, what are the other risk factors? Now, this is taken from, and you can see at the bottom here, the reference. So tonight's session is recorded. It'll be on YouTube. So for those of you who want to just sort of sit and absorb it tonight, that's fine, and maybe review it later at a later date. That's absolutely fine. And you can, if you really want to be sort of smarty pants about it, you can actually look at the journals. So if you're interested, so this is a very, very, very important paper in my view, showing how different factors are important in the development of heart disease. So this study was one where roughly 1,000 women presented in the US. It's a US study. They went to their doctor with symptoms, particularly like chest pain. So they were referred by their doctor to a cardiologist, to a heart specialist, and they underwent a particular type of test called an angiogram, which is a very specialized type of X-ray. And they were found at that stage to have varying levels of furring up of the arteries, we sometimes say. In other words, they had some reduction in blood flow in the heart, particularly. Now, those women were then followed up for 10 years. So they were seen on a regular basis, and what was tracked was how many of them actually died over that 10-year period, and what factors seemed to be the most important. So roughly 1,000 women, it's a little under 1,000, it's about 970, were tracked over a 10-year period to see what risk factors, what modifiable risk factors seem to be the most important. And it may surprise many of you that actually the number one factor was abdominal fat. So if we're carrying more weight around our abdomens, that seemed to be the most important factor. Being a diabetic was the next one. Chronic kidney disease came in at third. But one of the things that I haven't touched on so far tonight is that actually the number one cause for chronic kidney disease is actually diabetes. That's the principal cause. That's the main cause. So those two are actually slightly linked, as is high blood pressure. They often go together. And then the final one, the penultimate one, forgive me, is insulin resistance. Now that's slightly more technical, but insulin resistance and diabetes basically go hand in hand. Anybody who's diabetic is by definition, or anybody who has type 2 diabetes has insulin resistance. So those are connected. And blood fats. Now, I'm very specifically not using the word cholesterol because actually in this study, the type of blood fat was not actually cholesterol that seemed to be the problem. It was something slightly different called triglyceride, which is often overlooked by clinicians. So what we're actually seeing here is that all of these factors, all 6 of these factors, are in reality, they're linked. We're not actually dealing with 6 totally separate factors. We're dealing with 6 risk factors which are linked and are often referred to by the collective term metabolic syndrome. And this is actually incredibly important when we're considering how to really try and help patients with chronic kidney disease think about reducing that cardiovascular disease risk. We don't have to consider each of these in isolation. In fact, that makes no sense. Because they're all connected, there's almost certainly something underlying which is driving this. And that's the bit that Dr. Rutherford is now going to talk about. Over to you.
Thank you, Dr. Bardwaj. Yes, so now we're going to move on to talk about statins and the current NHS guidance, which changed about a year or so ago, which is that all patients with CKD should have a statin prescribed. Now, for those of you that don't know, statins lower cholesterol, and that is a type of blood fat. It may not be the most important blood fat as per that last slide, but at the moment, the theory is that the so-called bad cholesterol is a direct cause of blocked blood vessels, which are then a direct cause of heart attacks and strokes. So cholesterol is the type of fat that the body actually manufactures itself. It's a really important building block for a lot of our hormones that are important for us to survive and live. And also in particular, it's an important building block for vitamin D, which we recognize more and more is very important for both our metabolic health, our well-being, our mood, and our immune system. So cholesterol is important. We need to have cholesterol. But the theory, the kind of cholesterol theory of what causes heart disease is that if you lower cholesterol by taking a statin, then you will have a lower risk of heart disease and stroke. But like many things in life, the reality is probably a lot more complex. Now, I'm not screen sharing at the moment because in our experience, when we screen share is when we suddenly get jinxed and the connection fails. So I'm going to ask Dr. Bardwaj now to just move the slide deck on to the next slide. So up until last year, if you had been diagnosed with CKD, and another thing that we perhaps haven't mentioned is that people's eGFR fluctuates quite frequently. So sometimes you might dip a little bit below that level of 60 and we think, oh, you've got CKD, but then we recheck your levels and they've gone back to a more, a higher level, so above 60. So we then think, well, perhaps you haven't got CKD. So I know someone's mentioned they hadn't really realized that their kidneys weren't working properly. And it may be that eGFR is fluctuating in the higher 50s and the low 60s, and we're then labeling you as having CKD. And it can be a little tricky. But basically it just means that the kidneys are just aren't working quite as well as perhaps they used to. And up until last year, if you had CKD and you had never had a heart attack or a stroke, then the way we would calculate whether we thought we ought to be offering you a statin tablet to lower your cholesterol would be by calculating something called your Q risk. And here you can see the Q risk 3 calculator, which is the latest calculator. And I can't use a pointer, I'm afraid, because I'm not showing screens, but maybe Dr. Bardwaj can point out that within that Q risk calculation, CKD is labeled. So what you can see from this slide is that CKD was already built in to the Q risk calculation. And the Q risk calculator basically works out a person's risk of developing a heart attack or a stroke over the next 10 years. And traditionally, or for the last sort of 5 to 10 years or so, what we've been doing was if your Q risk score was above 10%, then we would be offering you a statin. Years ago, we started off by only offering it when your Q risk score was above 20%, and then it's gradually reduced down, and we've been offering more and more statins. Next slide, please. So for many years, patients who have had a stroke or a heart attack have been automatically put on a statin. But last year, we were told that all patients with CKD, no matter whether if they hadn't had a heart attack or a stroke or any previous cardiovascular problem, that they should also be put on a statin. Now, we're no longer advised that we should be calculating that Q risk score. And we know that CKD does it increases your Q risk. But I think like many doctors across the country, we are not entirely sure about that blanket advice to put everyone with, say, CKD onto a statin, because there can be some side effects with statins, and we think you need to be able to make an informed decision about that. So that's the reason really why we've developed this what we have been providing as a group consultation face-to-face in Woking, but now a webinar where we can actually go through things in detail, because as you can imagine, you come and see your GP or one of the other clinicians, you want to talk about CKD and statins. we have 10 minutes in a consultation to go through that. Well, already we're half an hour into this presentation. There's probably another half hour to go. So actually, to really fully inform you all, you need at least an hour really to go through things. And that's the reason partly for the presentation. That's a little aside. But anyway, so we're a bit worried about that blanket advice. Next slide, please. And we're not the only ones. So this is a paper that was published last year, and it alludes really to some disquiet amongst doctors regarding that blanket prescribing of statins. So we believe that as the conclusions in this paper suggest, that that decision still needs to be personalised, and we shouldn't just be saying, okay, you've got CKD, we're going to send you a prescription for a statin and tell you that you've got to go on it. And the paper states this, and it seems to us to make sense that, the benefits for otherwise healthy patients do appear to be relatively small. And that sentence at the bottom of this slide is the really important bit, that there needs to be shared decision-making. And shared decision-making obviously means being given all the information. So you need to know about the benefits versus the side effects of the statins. What we're going to be going through now is actually sort of going through the previous Q-risk scores, because we think they offer you a little bit more information really as to where you can see the pros and cons of statins. So if we move on to the next slide now, whilst the current guidance is that everyone with CKD should be put on a statin, I do think it's useful for us to have a look at these, what are called patient decision aids. And they've been produced by the National Institute for Clinical Excellence, sometimes known as NICE. You may have heard about it. And NICE basically produce guidelines for clinicians regarding treatment for various different conditions. And they produce these patient decision aids on whether, to help patients decide, dependent upon their Q-risk score, whether they would like to take up the offer of a statin or not. So NHS England guidance at the moment is that we should advise patients with a Q-risk score of 10% or more to take a statin. We should perhaps offer it to those lower than 10%. And what I'd say is that most of you, if you have CKD, are probably going to end up with a Q-risk 3 score in the old-fashioned way we would calculate your risk of probably between around about 15 to 30%. And that is very much dependent upon both your age and other illnesses. So actually, as you get older, it stands to reason, doesn't it, that as you get older, your Q-risk score is going to be higher. So what Q-risk is looking at is it's looking at, if you take 100 people who have a Q-risk score of 10%, as in this slide, and you give them all a statin tablet, and they take that statin every day for 10 years, how many of those people will not have a heart disease or a stroke? And by heart disease, what NICE mean is having either a heart attack or angina, or even just having been found maybe on some further investigations to have a blocked blood vessel. So some of you may have had an angiogram if you had chest pain, and the angiogram has shown some blocked arteries. Actually, hopefully none of you will have had that, because if you have got that, then the advice would be to go on a statin. But basically, heart disease means any form of heart attack, angina, blocked blood vessels. And obviously, I think we all know what stroke is. So if 100 people with a Q-risk score of 10% take a statin every day for 10 years, then 90 will not have heart disease or a stroke. But those 90 are the 90 who wouldn't have had a heart disease or a stroke anyway. 6 will have heart disease or a stroke despite taking the statin, which leaves 4 where the statin has prevented heart disease or a stroke. So 100 people take a statin for 10 years in order to prevent 4 people from having heart disease or a stroke. Now, normally, if we're doing this as a face-to-face thing, I will open this up to the audience and say, what do we make of that? I'm not sure if we've got any comments. I can't see the chat, I'm afraid now. Any comments in the chat? If we move on to the next slide, I'm going to crank it up a little bit more, and people may wish to sort of make some comments about those odds there. So again, if we crank it up to a Q-risk score of 20% and 100 people with a Q-risk score of 20% take a statin every day for 10 years, then 80 will not have heart disease or a stroke, who wouldn't have had one anyway. He wouldn't have had any disease anyway. 13 will have heart disease or a stroke despite taking the statin, which leaves 7 people where we've prevented illness, heart disease or stroke. So 100 people have to take a statin for 10 years in order to prevent 7 from having heart disease or a stroke. Next slide. This is really cranking it up to 30%. So if you have a Q-risk score of 30%, 100 people take a statin for 10 years every day, 70 will not have heart disease or a stroke, who wouldn't have had any illness anyway. 19 will have heart disease or a stroke despite taking the statin, which leaves 11 where we've prevented heart disease or a stroke by 100 people having taken the statin every day for 10 years. Any sort of comments in the chat on that at all?
I can't see the chat either, so we'll perhaps deal with them at the end, shall we?
Oh dear, there's always a glitch. That's probably from changing screens. Let's move on to the next slide. Okay, so those are the benefits. But what are the potential downsides of taking statins daily for a decade? So, unless you know the potential side effects, then you can't really make an informed decision about whether you want to take a statin or not. So that NICE patient decision aid that we just looked at, they also quote rates of harm related to statins. And what they state is that they say that 2 out of 100 people develop muscle pain because of the statin, and 1 out of 100 people who take the statin develop diabetes. Now, I'm not sure where those figures have come from, because NICE is very vague about their references in that patient decision aid, and they'd literally say from many large studies. But this slide is taken from a website called the NNT. NNT refers to numbers needed to treat, and it's a website that I would heartily recommend to everybody because it goes through pros and cons, benefits and harms of various different treatments. So numbers needed to treat, as I said, it stands for the numbers of people that need to take a medication in order that one person gains a benefit. And this website, the NNT, you can just Google it and find it, just put in the NNT. This website uses evidence obtained from something called the Cochrane database. And Cochrane is really the gold standard for medical research. It looks at what we call systematic reviews and gathers all the available evidence that's been researched worldwide. And side effects and benefits, according to Cochrane and the NNT on this slide, are, as you can see, a little bit different to the NICE patient decision aid. So, as we said before, on the NICE patient decision aid, that's a tongue twister, they are looking mainly at, they're looking at heart disease bulked altogether. So they put heart attacks, angina, any coronary artery vessel disease that's been found as heart disease. And they're looking over a 10-year period, whereas the NNT, it's looking at the numbers of those who've been taking statins for 5 years, not 10 years, okay? And the NNT figures look at an actual heart attack rate, not heart disease. So obviously, having an actual heart attack is more of a worry and more worrisome medically than having, say, found some minor coronary artery vessel disease on an investigation but having no symptoms. So I think the NNT information that we're given here, benefits and harms, is really looking at really quite significant harm, looking at heart attacks and strokes. Okay. So according to the NNT, the numbers needed to treat, nobody's life was saved by people taking a statin for 5 years. And this is patients who have never had any heart disease. So at the top, that title says statin drugs given for 5 years for heart disease prevention without known heart disease. So that would have been, that's anybody who hasn't had a heart attack or a stroke, okay? And that would have been up until about a year ago. That's what we would be looking at. We would classify somebody with CKD as having, because we were saying, well, you've never had an actual event, so you don't need to automatically be given a statin. So no one's life was saved. 1 heart attack was prevented for every 104 patients taking a statin, and 1 stroke was prevented for every 154 patients taking a statin, okay? So that is slightly different, as I said, from the numbers needed to treat on the NICE patient decision aid. The harms, or sometimes known as numbers needed to harm, or NNH, the harms, according to the NNT, show that 1 in 50 patients who took statins developed diabetes, who wouldn't have done otherwise. NICE says it's 1 in 100, but NNT says 1 in 50. But here they say 1 in 10 develop some type of muscle damage. And we don't have the figures here, but I think we as GPs know that many patients who take statins do get other sort of, less significant side effects. Initially, it can give you a bit of a jippy tummy. Some people have permanent kind of diarrhea or upset tummy as a result of taking statins. Some people find that they just feel a bit of brain fog, or they find that their sleep's affected. And as GPs, I think we probably see more of those kind of what would be considered low-grade side effects, but really aren't low-grade for the patients who experience them, than perhaps the specialists do. And that maybe doesn't always get reported in all the research. We also know that many patients tell us that they're taking the statins, but in reality, they aren't. So we need to have a think about why that might be. If we move on to the next slide now, please. So this slide gives us a little more context. Again, I'm aware that I haven't really got a pointer to be able to do this because I'm not controlling the slides. The data is a few years old, but it shows, if you look carefully, that many patients don't actually take their prescribed statins. So it's mainly North American data, and in column N, not sure if you can see that, maybe Vipin could point to it, you can see the numbers of patients that have been studied. So they're pretty big numbers of patients, really. So I think we can say that this information is quite relevant. And if you look at the inclusion criteria there, you can see why patients have been put on statins. So most patients have been put on the statin in these studies because they have already had an event. So they've had a heart attack or a stroke, or they've been found to have coronary artery disease. There's one study there that looks at what we would call primary prevention, which is where people have been put on the statins because they've got diabetes, but they haven't had a heart attack or a stroke. And as you can see, I think it's quite interesting that even patients who we're told are at highest risk, so they've had a heart attack, I think that's the one. It says that it's the 4th one down, I think, Fudi et al. They have high levels of not taking the statin. It's about a 50% drop-off rate. And Yang et al. Also have about a 50% drop-off rate. And I think this is telling us something, isn't it? That, we're trying to tell patients who haven't actually had a heart attack or a stroke, we're basically telling them, somebody with no symptoms, that they have to take a drug, that they need to medicate. And maybe, maybe some people just think, well, yeah, actually, forget that. I'm not going to take medications. There's that old joke about doctors, isn't there? They don't make you live longer. They just make you feel as though you're living longer. And it could be that perhaps the side effects of the statins are such that many patients decide, well, actually, I'm not going to take them. So that's food for thought there. If we move on to the next slide, I did want to put this in because you might be wondering, why do we give statins at all? And some of you may well have relatives or friends who have had heart attacks or strokes who are taking statins. And so this is looking at, again, from the NNT website, it's looking at the benefits of taking statins if you are known to have heart disease, as in you've had a heart attack or angina. And here what you can see is that one life is saved out of 83 patients taking a statin. But more importantly, 1 out of 39 patients taking a statin have a fatal heart attack prevented by taking the statin when they've already had or have a diagnosis of heart disease. So please don't tell your relatives to stop taking statins as a result of this this session. This session is really looking at CKD and people who've never had heart attacks or heart disease or strokes, and trying to sort of explain to all of you the pros and cons of taking statins, and so that you can make an informed decision about whether you want to take that or not. Now, if you perhaps have slipped through the net and you know that actually you have, for example, had a coronary angiogram at some point and been told that you do have some minor furring up of your arteries or coronary artery disease, then you should be taking a statin. If you're on a statin, don't stop taking it. So the advice still stands that if you have had a stroke or a heart attack, you should still take a statin. And that's probably, well, we think that may well be work because it's anti-inflammation, because we know that statins are anti-inflammatory, and it may not necessarily just be that it's because it lowers cholesterol. Next slide, please. Any questions?
So I'm going to suggest that we perhaps do that at the end, because neither you nor I can see the...
Okay, fair enough. I'll move on quickly because I'm conscious we're actually 10 to 8 now as well. So if we move on to the next slide, what I want to do now is really introduce you to the insulin model of cardiovascular disease. And it's what Dr. Bhardwaj alluded to previously. If we go on now to the next slide, alluded previously to metabolic syndrome, and that is likely the root cause of heart disease and strokes. And CKD may well be related in that we know that a lot of pre-diabetics and diabetics are more at risk of CKD. So if we could move on to the insulin and cortisol model of cardiovascular disease slide, brilliant. So first thing to say is really that this slide is not remotely controversial at all. Everything that happens in our bodies is as a result of our hormones. So metabolic syndrome, diabetes, blood pressure, being overweight, having those abnormal blood fats, in particular that abnormally high blood fat called triglyceride, is largely about 2 different hormones, one called insulin, which you may have heard of because it's related to diabetes, and the other one called cortisol, which again you might have heard of because when we're talking about stress, we talk about high levels of cortisol and adrenaline. So if we start on the left-hand side of this slide, and we're looking about what triggers high levels of insulin, and here we're talking about patients who may have what we call insulin resistance or pre-diabetes or diabetes. We're not talking about type 1 diabetics. They have very low levels of insulin and they need to replace the insulin with injections. So we're not talking about them. We're talking about what triggers high levels of insulin resistance, and then increases people's risk of developing diabetes and pre-diabetes. And what we know is that that's related to diet. So if you have a diet that's high in carbohydrates, so that's sugar and starch, so not just cakes and very high sugary things, but also things like bread and pasta and cereal, which are also full of carbohydrates and which are converted in the body to sugar. Then if you have a diet high in carbohydrate, then that tends to increase your insulin levels. And this is the important bit. Insulin is a fat storage hormone. So what insulin does is it means that you put on weight, you put on fat, you get that, you start carrying weight around your middle. Again, one of those risk factors that Dr. Bhardwaj alluded to previously about how having, carrying your weight around the middle is a big risk factor for heart disease, cardiovascular disease. So these are the sort of things that will increase your insulin levels. And then if we look on the right-hand side of the slide, lifestyle has a big influence on cortisol levels. So when we're really stressed and we're not getting much sleep, we're perhaps, living somewhere where we don't have access to outdoor spaces, because we know that, getting outside and exercising, especially in the sunshine, and making sure that we have time with nature, that all these things, if we don't have access to them, being overweight as well, these can all increase our cortisol levels. And cortisol, guess what? That also increases sugar levels, which in turn then increase insulin levels. And what happens there is that we, for various reasons, which I'm not going to go into because it's a bit complicated, but those hormones means that we hold on to salt. So if we're retaining a lot of salt, our blood pressure goes up. Having a high blood pressure is another risk factor for having a heart attack or a stroke. We store that sugar as fat in our bodies, which again can affect our liver and give us something called fatty liver that some of you may have heard of. The blood pressure increases again, and that then results in us developing CKD and diabetes, and then that is the risk factor for developing cardiovascular disease. So if we go on to the next slide, this is a quick reminder that actually what we need to try and do if we really want to prevent cardiovascular disease might mean that we need to keep our waistline trim. So basically what we're talking about here is a healthy waist for men is about 35 inches, for those of you that aren't on metric yet, and for women about 30 inches. Not quite sure how many of us conform to that, but yeah, you want to make sure that you keep your waist nice and slim, and that if you suddenly notice that it's getting difficult to do up a few buttons on your trousers, then that might be the time to sort of think about making some lifestyle changes. And if we move on to the next slide, then again, big advice to everybody here is try never ever to become diabetic. If you're pre-diabetic, do something about it. Come to one of our group sessions on pre-diabetes and try and get yourself into a normal range. The way that we diagnose diabetes and pre-diabetes is through a test called the HbA1c. Very likely that many of you will have already had that done. You can look on the NHS app and see your HbA1c level. Basically, you want to keep your HbA1c less than 42 in a normal range. Okay, and then if we move on to the next slide. So this is a reminder of the slide from earlier on that Dr. Bardwaj went through. It's unbelievable the positive changes that people can make by making just a few small lifestyle changes. It really can reduce both our insulin and cortisol levels, and that in turn can reduce our risk of cardiovascular disease. Next slide. So this is just, what are the next steps now? We're coming up to almost 8 o'clock, so we're going to sort of wrap things up a little bit. But hopefully, having listened to our explanation about CKD, having gone through the previous patient decision aids that NICE have produced and the NNT have shown, you'll be thinking now a little bit about, do I want to take a statin or not? Is a statin right for me? You'll be able to have another look at this presentation. It's all recorded, so you can look back at it. We understand that it's quite a big decision to make to start taking medication, particularly if you don't take medication for anything else. So it may take you a little bit of time to think about things. What we are going to do is we are going to send a prescription to your pharmacy for the statin tablet that NHS England recommend we give to patients with CKD, which is atorvastatin, and that's at a 20 milligram dose. And it's completely your decision as to whether you decide to pick that prescription up or not. So it probably is going to take us, there's quite a few of you, so it may take us a little bit of time just to get all those prescriptions out. So give us a couple of weeks, and that will give you time as well to make that fully informed decision as to whether you want to take the statin or not. And then you can just go along to your nominated pharmacy and collect it. And then next month, after you've had time to really think about things, we will send you a text message asking you whether you've decided to take a statin or not, or whether you prefer not to. Please reply to that text message if you can, because what we'll do is if you do decide that you don't want the statin any longer, then we will actually code you as having declined the statin and we won't keep bothering you about it. But if you do decide to take the statin, then we'll know, and we can then make sure that our prescription clerks have added the statin to your repeat prescription. If for some reason that doesn't quite happen as a result of the text message, then just make sure that if you start taking the statin, that if it isn't on your next repeat prescription, that you then make sure you request for it, or you request it. Moving on to the next slide, please. So if you do decide to take the statin, then automatically what we'll do is we'll ask you to have a repeat cholesterol test and a liver function test 3 months after taking the statin. And that's because statins can sometimes affect the liver, not very frequently, but sometimes they do. So we need to just monitor that. And if you are on a statin, then from now on, you'll have an annual blood test to check your cholesterol level, to check that the statin's working. And we monitor that by seeing whether it reduces your bad cholesterol. That will be ongoing. So that will be every year. Okay. But obviously, if we code you as having declined a statin, then if you change your mind, you do need to come back and tell us. Because if you don't, you don't let us know, then that you've declined the statin, then we will keep offering you that choice. And we'll ask you to come along to one of our group consultations like this, or listen into the webinar. Next slide, please. So we're on to that, and finally, and if you move on to the next slide. So I've got this slide here because, we've been running face-to-face and virtual group sessions now at Wokingham for over 8 years. And one of the things we've learned from having run them for so long is that our profession, that's the medical profession, we're actually quite poor sometimes at giving patients hope. We tend to say, that's your diagnosis, take the pills. And I think there's a real appetite out there where patients don't actually really want to take pills, and they would prefer to make changes to their lifestyle. And actually the evidence does seem to suggest that making lifestyle changes actually results in better outcomes than just taking the pills. So hopefully, having heard what we've had to say tonight, you'll understand that perhaps the real way to prevent heart attacks and strokes is to improve your metabolic health. And more importantly, to never ever develop diabetes. And if you do develop pre-diabetes or diabetes itself, then this is a little reminder just that to all our patients out there that we will be restarting our new series of diabetes reversal programs and pre-diabetes group sessions in April. If you're diabetic or pre-diabetic, you'll receive an invitation to one of those sessions. Please, if you haven't already, give it a go. If you have tried it and have fallen off the bandwagon a little bit, then please come back again. It's just a good reminder, really, just to sort of give you a little nudge to generally making some lifestyle changes. And if you do that, then not only will you reduce your risk of heart attacks and strokes, but you'll feel better, and you'll improve both your physical and your mental health. So don't think there's nothing you can do and that the only choice is medication and ill health. There is hope. And by making a few small lifestyle changes, you really can reduce your risk of a heart attack or stroke. And if you'd like any more help with this, then, and if you're not diabetic or pre-diabetic, and won't therefore be invited to our group sessions automatically, then you can ask one of us at the surgery to refer you on to one of our health and wellbeing coaches, and they will be able to help you with making some lifestyle changes. And if we move to the last slide, that's finally a thank you for giving up your Monday evening and listening in. And any questions now? Let's hope we can see the questions.
So so I've stopped sharing, and wow, we've got quite a lot of comments.
Okay,
so it looks as though while I was talking, you were quite busy putting comments in.
Yeah, you obviously had a bit of a rest whilst I was talking, did you? You went and had a cup of tea.
Okay, all right. So actually, I don't think I can see any new questions that you haven't already dealt with by the looks of things.
Okay.
Actually, I'm not sure I'm pronouncing this right. Deauville Purvis saying, I have one kidney. Do I need to take a statin? So the in a sense, Deauville Purvis, the number of kidneys are, to an extent, not that relevant in this context. The key thing really is what the eGFR is, and the best way to do that is to look at the NHS app. So because this is going to go onto YouTube, I have to be careful what I say about some of these sort of NHS IT things over the years. But I'll be candid and say that the NHS app is absolutely brilliant in my experience. I think it's a really good thing. People can look at their record, look at their tests, ask for medication, etc. It's a very, very useful piece of IT. So have a look at the eGFR, see where you land with respect to some of the slides that we showed earlier on. If your eGFR, as is most likely, is going to be in the range sort of 40 to 60, then your decision is really the same as anybody else's. And I think it's worth saying that this is a topic which really cannot be dealt with in a sort of a quick 10-minute consultation on a sort of February morning or January morning or whatever it might be. And that's why we've sort of put together this session so that we can give people the time to go through some of the benefits, the risks, and actually offer an approach that doesn't involve medication. So hopefully that answers that question. And it's important now, I think, to perhaps just take some time to reflect, maybe watch this back again, and just realize that those of you who've joined tonight, or perhaps those that join another time, it's no exaggeration to say that you will now be better informed than many clinicians. That's a strong statement, but some of the stuff that we've showed tonight actually just gets a bit lost in the kind of the fog of war almost. So yeah, let's hope that's been helpful. No new questions. So thank you, everybody, for joining. And we'll perhaps call it a day. You can perhaps go off and have your tea. Remember, not too many carbohydrates, not too much sugar. As a good way to improve your metabolic health. Helen, did you want to say anything else? Closing.
I think we've got one further question, which I think we should answer because it's a good one. So yes. One of our patients out there, David, already has quite a lot of muscular aches and pains, and he's worried that is there a higher risk that it will get worse if you take statins? I think, David, the answer is we don't know. What we do know as GPs is that we do fairly regularly see patients who come in to see us who are complaining of aches and pains, and sometimes what I'll then do if they're on a statin is I'll trial taking them off the statin, and on a fairly regular basis people feel better. So I think that's one of your considerations when you're weighing up the risks versus the benefits of taking the statin. And another option is that you give it a go. You might decide, well, actually, I've had a look at all the information tonight. I'd quite like to give them a trial. And then if you do find your pains get worse, then you say, well, actually, I was giving it a go just to see what happened, and it seems to be worse. What should happen is on stopping the statin, the aches and pains should get better. So it shouldn't be that they permanently worsen things for you. Hopefully that answers your question. Anything else to add on that one?
Nope. That's fine. Fantastic. Well, I'll bring it to a close now. So thanks, everybody, and have a nice rest of your evening.
Yeah, take care, everyone. Bye-bye.